Hi, my name is Ami Hayashi, and this is our poster on hepatocellular carcinoma with extensive macrovascular invasion. As an introduction, worldwide, liver cancer is the third leading cause of cancer-related deaths, with the majority of the cases being hepatocellular carcinoma. Up to 40% of patients with HCC present with concurrent macrovascular invasion. There are many grading systems for these tumors. However, one such is Barcelona Clinic Liver Cancer Staging Classification, which helps to guide treatment strategies. Patients with portal vein invasion are classified under this system as advanced hepatocellular carcinoma, stage C. Moving on to the case presentation. We have a middle-aged man with a past medical history of hypertension and diabetes who presented to our emergency department with 2 months of progressive shortness of breath and bilateral lower extremity swelling. On history, his family history was not notable for any malignancies. And on social history, patient does not have a history of tobacco, alcohol, or other types of drug use. And of note, the patient currently lives in American Samoa. For medications, the patient is just taking medications treating his hypertension and diabetes. On physical exam, the patient was alert and oriented, pleasant, and conversant. And of note, he did have 2+ bilateral pitting edema to the knees, and also scattered bruising over the extremities. Otherwise, vitals and physical exam were unremarkable. On patient's labs, of note, he had an elevated BUN to 70, creatinine of 2.8, and liver enzymes were also elevated. AST was 701, ALT was 441. Patient also had an elevated D-dimer at 16.41, and a positive hepatitis B surface antigen. Later on, an alpha-fetoprotein level was also sent out and was elevated. Given these abnormal lab findings in the setting of dyspnea, a ventilation perfusion lung scan was ordered, which showed that there was a high probability of PE. Additionally, due to the patient's abnormal liver function tests, an abdominal ultrasound was performed, revealing multiple right hepatic lobe lesions. A CT chest, abdomen, pelvis was also performed, which showed a large hepatic mass extending from the right hepatic vein into the IVC, into the right atrium and the right ventricle, as seen in Figure 1. The imaging was felt to be consistent with hepatocellular carcinoma. This scan also showed that there were bilateral pulmonary emboli, as seen in Figure 2. After multidisciplinary meetings and tumor boards, it was determined that the hepatic mass itself was likely unresectable. At that time, adalimumab and bevacizumab combination therapy was determined to be the best clinical course forward. However, the right atrial and right ventricle extension posed a risk for a future catastrophic PE during treatment, and thus the decision was made to resect the cardiac mass and also perform a pulmonary embolectomy. Pathology from both the RA tumor and the pulmonary emboli were consistent with HCC, as noted in Figure 3. In conclusion, the patient was diagnosed with hepatocellular carcinoma with macrovascular invasion, characterized as BCLC stage C. It's likely, given that the patient had a positive hepatitis B antigen, that patient had undiagnosed hepatitis B infection, which was the cause of the hepatocellular carcinoma. We created this poster to highlight this unusual presentation of mild subacute dyspnea and bilateral lower extremity edema. This case also led us to investigate currently what is the state of hepatocellular carcinoma diagnosis and treatment. Our first question that came up was, how common is it for patients to present with such extensive macrovascular invasion? And surprisingly, in some studies, 40% of those with hepatocellular carcinoma also have macrovascular invasion. It's important to determine the extent of the macrovascular invasion because this guides therapy and resectability. Imaging can also be a very important modality for clarifying if macrovascular invasion or is tumor or bland thrombus. Second, we were interested in investigating what new therapies exist for hepatocellular carcinoma. When conversing with our hepatology and oncology colleagues, they noted that currently the field is rapidly evolving with multiple therapies published frequently. In fact, one article published in 2020 in the New England Journal by Finn et al. Highlighted adalimumab and bevacizumab combination therapy for unresectable hepatocellular carcinoma. Our colleagues also highlighted how important genetic testing may become in the future. In our case, our colleagues highlighted CNNB1 as one potential marker, which may help to predict response to immunotherapy. But as there's rapidly evolving therapies within this field, there's potentially more markers to look out for in the future. Thank you very much.